Sagar sir, please start.
Sagar, you are
सागर
muted.
सर स्टार्ट करा, अनम्यूट करा आणि स्टार्ट करा.
Kindly unmute yourself. Kindly unmute yourself and start.
Good evening, everyone. I welcome everyone to today's discussion on pediatric rheumatology in office practice. As we know, early recognition and management of the rheumatic conditions in children can significantly impact their long-term outcomes and quality of life. Today, we explore practical approaches that can be implemented directly in your clinical settings. Today, we have Dr. Amol Pawar, the Joint National Convener, Dr. Minas sir, and Dr. Sanjay Deshmukh with us. I request Dr. Sachin Patil to welcome our dignitaries.
Good evening, everyone. Myself, Dr. Sachin Patil, MAHAIAP Executive Board Member 2025 from Yavatmal. Welcome you all delegates, all dear faculties for this today's academic session. Today is the fifth episode of Friday Ka Punch MAHAIP Ka Sun. And the today's topic is pediatric rheumatology in office practice. So we have two experts for this and five eminent speakers all over the region from Maharashtra. So I now request, as our President Dr. Sanjay Pakmode sir is not there, I request Dr. Amol Pawar sir to give a welcome address. Over to you, Amol sir.
Thank you, Dr. Sachin, Dr. Sagar sir. On behalf of Maharashtra IIP, I welcome today's both the experts, Dr. Vijay Vishwanathan sir and Dr. Girish Subramaniam sir. We are very fortunate to catch hold of Dr. Girish sir. In last 2-3 years, we tried him, and for one session he came and he has given guidance to all the speakers during that time. And now also Dr. Vijay Vishwanathan, we all know him. He's a great pediatric rheumatologist working all over Navi Mumbai and Thane and parts of Mumbai also. This program, all 5 speakers are chosen from all various zones of Maharashtra. Today's Alve ma'am, then Dr. Gopal Guge, then Dr. Deepa Maitre ma'am, and Dr. Swapnil Giri from Hingoli. They will be on these various topics. And pediatric rheumatology is a different subject. We all know whenever we come across these patients, we have to correlate these patients clinically and according to labs. And finally, for treatment, we have to send this patient to pediatric rheumatologist. So there will sir will be guiding, Vijay sir and Girish sir will be guiding us when to refer and how to correlate these patients clinically. So I once again welcome other dignitaries like Dr. Sanjay Deshmukh sir, Dr. Minas sir, Dr. Anand Deshpande sir is there, and then all the office bearers from Maharashtra district branches and all the delegates. So wish you all happy learning. And today's moderator, Dr. Sagar Wag sir from Nagar and Dr. Sachin Patil. So wish you all the best for the success of this session. Thank you. Over to you, Sachin.
Thank you, Amol sir, for your guidance. Now I request our MAHAIP convener, Dr. Sanjay Deshmukh sir, for the word of wisdoms. Over to you, Sanjay Deshmukh sir.
Good evening. As a convener MAHAIP, I welcome you all for our Friday Ka Punch. As you know, this is the 5th episode, and this is the episode where every month we take one subspecialty, and today is rheumatology. And I welcome our esteemed expert, Dr. Girish Bansal from my own town, Nagpur, and Dr. Vijay Vishwanathan from Mumbai. And as this is a platform for the young dynamic pediatricians all over Maharashtra, and I welcome those all young faculty, Dr. Rupali, Dr. Gopal, Dr. Swapnil, Dr. Deepa, and Dr. Atul, because where this platform provided by MAHAIP will definitely bring more and more pediatricians to the MAHAIP platform. So my best wishes to Dr. Sagar Bagh and Dr. Sachin Patil, and I wish all the best to all the speakers today. Thank you.
Thank you, Sanjay sir, for setting the tone of today's scientific agenda. Now over to you, Dr. Sagarwak sir, for further proceedings.
Yeah, I request Madam to just put the hello. I welcome Dr. Girish sir and Dr. Vijay sir, who is the expert for today. Dr. Girish Subramaniam, he is a consultant pediatrician and pediatric rheumatologist from Nagpur and has a more than 25 years of experience in general pediatrics and over 10 years in pediatric rheumatology. We have another expert with us, Dr. Vijay Vishwanathan. Dr. Vijay Vishwanathan, has done his postdoctoral fellowship in pediatric rheumatology from the Princess Margaret Hospital for Children, Perth, University of Western Australia. He is a consultant pediatric rheumatologist, Jupiter Hospital, Thane, Apollo Children's Hospital, Navi Mumbai, and he was a chairperson for Pediatric Rheumatology Society of India, IAP, from 2022 to 2024. He has number of academic achievements in his name: 19 international publications, 32 national publications, 8 international posters, 36 national posters, 10 chapters in textbooks, and more than 200 talks at various major pediatric specialty conferences. So I welcome both all the two eminent experts who are there today, and we'll start with the today's first talk. Dr. Rupali Salve.
Yes, thank you, sir.
Dr. Rupali Salve, she is a practicing pediatrician and she is from Yavatmal. I request Dr. Rupali Salve madam to start the topic.
Yes, sir. Good evening, all. Thank you, MAHAIAP, for giving me this opportunity. So, my topic is approach to arthritis. So, joint diseases and musculoskeletal diseases, they are increasing continuously, and it is a growing childhood health problem. So, confusion over the terminologies and lack of awareness of this condition can probably contribute to its under recognition. So, if the child presenting with arthritis or joint pain is always a diagnostic challenge, even for the most experienced clinician. Now, when the patient comes to us, we have to ask few questions: whether this is arthritis or arthralgia, whether the problem is acute or chronic, whether single joint is involved or multiple joints are involved, whether the child is well or sick, only musculoskeletal illness is there, or it is associated with some systemic illness. So remember this: joint pain is not an arthritis. Pain in joint is always an arthralgia, and when this pain in joint is associated with swelling and signs of inflammation, then we call this as a arthritis. Now the next is whether it is acute versus chronic. So for practical purposes, when it lasts for less than 6 weeks, we call this as an acute. Here pain is the prominent symptom, and it is often associated with infection or injury. Rather in chronic, it lasts more than 6 weeks, and swelling and stiffness are the prominent symptom rather than pain. Now, a famous quote from Sir William Wasler: when an arthritis patient walked in front door, I wanted to walk out the back. So a carefully conducted history and physical examination are the initial and important step for narrowing differential diagnosis, and it will guide us for the diagnosis. Now, in history, we have to ask few questions: whether a single joint or multiple joint is involved, whether this problem is acute or chronic, any associated symptoms like fever, rash, weight loss, or sore throat is there or not, whether it is associated with trauma, whether the pain is more in night or there is morning stiffness, whether it interferes with normal function, or whether there is any contact of TB. Ask about family history of psoriasis or other autoimmune diseases or coagulation disorder, and ask about the history of travel. Now, in examination, we have to see whether the child is well or sick, whether pain is there or versus affect is there. Now, we have to do a detailed musculoskeletal examination. While doing examination, then we have to see whether there is joint restriction, whether there is hypermobility, which joint they are involved, whether it is a peripheral joint or axial skeletal joints are involved, whether there are any systemic findings or extra-articular features like rashes and whites. So we'll see one by one. So now in history taking, so age is very important because some diseases, they are very common in early childhood, like polyarthritis, GI, or Kawasaki disease. It is seen in early childhood, and like enthesitis related arthritis or SLE, it is seen in late childhood. Now about the sex, polyarthritis, polyarticular GI or SLE, it is common in girl child, and Kawasaki disease or enthesitis related arthritis, it is more common in boys. Now systemic onset GI has equal sex distribution. Then the next thing in history is whether this is acute problem or chronic. We have already seen, if it is an acute problem, think of septic arthritis or arthritis associated with Kawasaki disease or henoch-Schwann purpura. And in chronic, then it could be a polyarthritis GI or sarcoidosis. Now about pain, ask about morning stiffness. If morning stiffness is there, it could be inflammatory arthritis. And night pain, they are always scary, could be associated with malignancy. Then the next thing is ask whether the pain gets better with rest or pain gets better with activity. If it gets better with rest, we will think of mechanical problem. And if it is better with activity, then think of inflammatory problem. Now, next thing is whether the lower extremities are involved or upper or lower extremities are involved or axial skeletal spine is involved. If it is axial skeletal spine, then we'll think of think of TB, malignancy, enthesitis related problem. Now then ask for a fever and other constitutional symptoms like weight loss, anorexia, night sweat, nocturnal pain, and some extra articular features like diarrhea, urethral discharge, ocular symptoms, rash, headache, etc. Now ask about precipitating factor, whether trauma is there, infection, immunization, drug exposure, or any exposure to patient with TB. And in personal or family history, bleeding diathesis or HLA-B27 associated disease, we have to ask about. Now, remember that arthritis, the diagnosis of arthritis revolves around recognition of pattern of a joint involvement. And examination not only determines which joint is involved at one time, but over a period of time, how the joint evolution is there. Now, in physical examination, there are some pointers, and we have to ask this question. The first thing is the involvement is articular or periarticular? If the involvement is articular, then it is associated with diffuse pain, joint swelling, and limitation of active and passive movement. But if periarticular structures are involved, the pain is present only during active movement and there will be a point tenderness. The next question is the involvement inflammatory or non-inflammatory? So in inflammatory, now the pain is associated with morning stiffness and there will be a diffuse joint swelling and tenderness. And inflammatory is often associated with systemic manifestation and there will be elevated acute phase reaction. In non-inflammatory cases, pain is present during the physical activity and it improves with rest and there will be no positive laboratory findings. Now the next thing is involvement is acute or chronic. So if patient comes within hours with swelling, then think of trauma or bleeding diathesis. If it is acute, like days to week, then think of infection, rheumatic fever, neoplasia, connective tissue disorder, etc. And if it is chronic, it means more than 6 weeks involvement is there, then think of GI and chronic infection like tuberculosis. Now the next most important question is how many joints are affected, whether monoarticular like single joint involvement, whether it is oligoarticular means 4 or late joints are involved, and if it is polyarticular means 5 or more joints are involved. Now if it is more acute monoarthritis means the symptoms are less than 6 weeks and it a single joint is involved, the next question is whether the child is sick or whether the child is well. If the child is sick and associated and it is associated with fever, then our DDs are like septic arthritis, reactive arthritis, Kawasaki disease, malignancy, or systemic onset GI. And if it is monoarthritis, sick child but not associated with fever, then our DDs are like partially treated sepsis or malignancy. Again, if it is the acute monoarthritis, well child is there and with the history of significant trauma, then it could be associated with fracture or mechanical derangement. And if it is not associated with significant trauma, then it could be bleeding disorder or neoplasm. If there is chronic monoarthritis, means the symptoms are there for more than 6 weeks and a single joint is involved, again we have to ask the same question, whether the child is well or whether the child is sick. If the child is sick, then the DDs are partially treated septic arthritis or reactive arthritis, SLE, or systemic onset GI. And if there is a well child, then our DDs like enthesitis related or psoriatic arthritis or oligoarticular GI. Now, our next question is there any axial or peripheral joint involvement is there? If it is axial, think of enthesitis related arthritis. Axial joint or sacroiliac joint or sternoclavicular joint. And if the peripheral joints are involved, like the extremities of shoulder or hip involvement is there, it is found in other arthritis. Now, the next most important question is whether the involvement is additive, migratory, or intermittent. So, what is additive? Additive means a new joint involvement over and above the already involved joint. It is seen in polyarticular GI. Migratory means one joint is involved, there is a complete remission, and after a complete remission, there is involvement of another joint. It is seen in acute rheumatic fever. And intermittent arthritis means there is a complete remission of sign and symptoms followed by a next recurrence in same or other joint. Now, the next question is whether the involvement is symmetrical or asymmetrical. And then we'll see in examination whether the arthritis is deforming or non-deforming. Then the next is whether is there any association with enthesitis. So what do you mean by enthesitis? It is the inflammation at the attachment of tendon or ligament. And diagnosis of enthesitis related arthritis is strongly supported by presence of marked tenderness on patella or at the tibial tuberosity or at the attachment of Achilles tendon. Now then in examination, look for fever because it is an emergency condition. Then look for skin rashes, palpable purpura, peeling of skin, pigmentation or nodules. In eyes, look for conjunctivitis, iritis. In oral cavity, look for ulcers, strawberry tongue, cracked nipple. In nails, you can see pitting or clubbing. Look for lymphadenopathy, hepatosplenomegaly. The most important thing in examination is PGALS, that is pediatric gait, arm, leg, and spine examination. And lastly, in examination, we'll see joint. In this, we have to inspect the skin for warmness, redness, swelling, soft tissue involvement, or passive and active range of movement. So I won't talk much about investigation, but remember that 90% of diagnosis of arthritis is made on history and examination. Investigation plays a very little role. Now, PGAS, I'll just talk for just 2 minutes. It is a musculoskeletal screening examination and it has excellent sensitivity and it is very quick to perform. So every pediatrician in office practice can use this PGAS examination to determine which joints are involved. Now, few facts or take-home message from this talk is arthritis and arthritis-like symptoms can be a presentation of systemic disease like leukemia or TB. Many rheumatological diseases have extra-articular manifestation like renal, pulmonary, skin, cardiac, or ophthalmic. Identification of musculoskeletal emergencies like septic arthritis or SOJI is very much important for management purpose. And as several rheumatological diseases evolve over a period of time, it may not be possible to conclude a diagnosis at first visit. And a recognition of pattern of arthritis is a very important component for diagnosis. Thank you very much and thank you for patiently listening.
I request Dr. Vijay sir to please.
I think Dr. Girish can start off.
Okay.
Okay.
First and foremost, we must compliment Dr. Rupali for an outstanding presentation.
Thank you,
She
sir.
stuck to time. She stuck to time. Very lucid, and you highlighted the important points wonderfully. Good. Congratulations. I don't think I'm much to add. Just a few points that I would like to emphasize. If you have nocturnal pain, it is never GI. If the pain is severe enough for the child to be woken up at night, it is not GI. Mostly, it will turn out to be leukemia. This one clue will often help you pick up leukemia. Another important clue to leukemia, which she mentioned in passing, is that oftentimes the pain is migratory pain. It is periarticular pain and migratory pain. Like rheumatic fever, the pain of leukemia is often migratory. If the child is grossly symptomatic as far as joints are concerned, consider that JI is unlikely. JI is a condition where the symptoms are not very striking. As a matter of fact, in olivarticular GIA, many times you will not get any symptoms at all. So if the child is grossly symptomatic, consider something away from GIA. The child is unable to walk, he is not able to sleep properly at night. GIA is an unlikely diagnosis. And lastly, it must be emphasized again and again. JIA stands for juvenile idiopathic arthritis. The key word here is idiopathic. So it's a diagnosis of exclusion. You have to rule out all other causes of arthritis, and then only you can say that the patient has JIA. So you must have a list of differential diagnosis in mind. And if you want to have a good list of differential diagnosis, you can go back over the presentation by Dr. Gopali here. And you should also give you further clues on how to go about approach by asking a few questions. Thank you, Dr. Gopali.
Thank you, sir.
Dr. Vijay, sir.
I'll reserve my comments for the end of the presentations, because what I planned was once we let the speakers have their say, I might be able to sum up all the presentations in about 5 to 6 slides at the end.
Okay.
Having said that, congratulations, Dr. Rupali, because you've done a tremendous job. What we have been doing over 10 years, you summed up in just 20 minutes or so, maybe even 10 minutes. The only message from now on and for throughout the whole presentation is a good history taking followed by a good examination puts you to recognize the pattern. At least you will find out which chapter in the textbook you need to see. And then the investigations are just to take you to the right paragraph and the word. I'll sum up whatever Dr. Rupali has said in my last few slides at the end of it, so that people can take home relevant messages. So I guess let's move on to the next presentation.
Thank you, sir. Our next speaker, Dr. Gopal Guge, he will speak on approach to primary vasculitis. Dr. Gopal Guge, he is from IIP Palghar, Balaji Children Hospital, Boisar. I request Dr. Gopal Guge to start his lecture.
I'm sharing my screen. Good evening, everyone. Office bearers of thank you, office bearers of MAHAIP for allowing me to speak on this topic. The topic is approach to primary vasculitis in children. Introduction: vasculitis encompasses the heterogeneous group of diseases characterized by inflammation and damage to the blood vessel wall. The clinical presentation and severity depends on the size and location of blood vessels where they occur. Although primary vasculitis is less prevalent in pediatric population than adults, but most common conditions like Kawasaki disease and HSP are common. The early identification and management is very important because as prominent interventions can mitigate the disease progression and long-term damage to the patient. Here is the classification of childhood vasculitis according to the European League Against Rheumatology. We'll go through the main diseases instead of going in all minor diseases. Like here is the criteria and category of the vasculitis. The predominantly large vessel, involving the predominantly large vessel, example is Takayasu's arthritis. Criteria for diagnosis is angiographic abnormalities of the aorta and its branches, and at least one of the following: the pulse deficit or the systolic BP difference of more than 10 mm of Hg between limbs, bruise or thrills heard over the aorta or its branches, hypertension, and elevated acute phase reactions like ESR and CRP. Predominantly medium-sized vessels, example is Kawasaki disease. The criteria for diagnosis is fever for more than 5 days and at least 4 of the 5 principal clinical features like bilateral conjunctival injection, oral mucosal membrane changes, the exanthematous rash polymorphous, and the peripheral or extremity changes, perineal or extremity changes, cervical lymphadenopathy. In few cases, we come across the less clinical features than the fever for more than 5 days and 2 to 3 clinical features. Then we call it as incomplete Kawasaki disease. If it shows the if this patient shows the coronary artery changes on the 2D echo. Predominantly small vessel vasculitis. Example is venous tunnel purpura, is also called as IG vasculitis. Criteria for diagnosis is purpura, which commonly involves the lower limbs. It appears in crops or pitaceae without thrombocytopenia, and one or more of the following symptoms like diffuse abdominal pain, arthritis or arthralgia, kidney involvement in the form of hematuria or proteinuria, and the pathologic finding of leukocytoclastic vasculitis. We'll go through cases. Case number 1, 4-year male child brought in casualty with chief complaint of high-grade fevers in 6 days. The temperature went up to 104 at the home, which unresponsive to paracetamol. On day 3 of illness, this child developed bilateral conjunctival injection, strawberry tongue, and rash on limbs. On day 5, this child exhibited swelling and redness of hands and feet, and also this child is irritable. Physical examination found temperature of 101, heart rate of 120, with BP of 95/60. On general examination, this child is irritable. Diffuse rash was there on trunk and limbs. Bilateral conjunctival injection was there without any discharge. The strawberry tongue and cracked lips also seen. The neck examination showed the enlarged tender 2.5 centimeter right anterior cervical lymph node. So lab findings were like high WBC count of 16,200 with thrombocytosis, raised ESR, CRP, and raised liver enzymes. Urine analysis showed the sterile pyorrhea. 2D echo was performed on day 6 of illness, which showed the mild dilatation of left coronary artery. The diagnosis in this case was complete Kawasaki disease based on the criteria seen above: fever for more than 5 days, and four of the 5 clinical features with coronary artery involved. So, when to suspect Kawasaki disease? Prolonged fever for more than 5 days, continuous fever with no obvious cause, and in infants less than 6 months with unexplained fever for more than 7 days and irritable with no obvious reasons, where we should consider 2D echo. Differential diagnosis for Kawasaki disease like viral infections like adenovirus, Epstein-Barr virus, measles, streptococcal throat infection with suppurative adenitis, and some systemic illnesses like systemic inflammatory disorders like rheumatic fever, JI. So, regarding criteria for Kawasaki disease, classic criteria and incomplete, typical criteria and incomplete Kawasaki disease. Classic criteria where the patient has fever and 4 or more of the typical principal clinical features of Kawasaki disease. Incomplete Kawasaki disease is where the fever is there, but all 4 to 5 classical principal clinical features are not there. It's called as a incomplete Kawasaki disease. But in that case, we should have the findings on 2D echo. So these clinical features tend to appear sequentially, which helps to differentiate Kawasaki disease from other disorders. Like in acute phase, the conjunctival redness and is there, which is usually bilateral, non-purulent, and painless, which spare the limbus. Oral changes like cracked lips and strawberry tongue. Cervical lymphadenopathy is usually unilateral and includes at least one lymph node more than 1.5 centimeter. The polymorphous rash usually occurs within 5 days after fever onset and may present as generalized exanthema. The toe changes appear very late. Whereas in incomplete criteria, the patient do not fulfill the classic criteria for the Kawasaki disease. It's more common in younger infants and older children. So it should be suspected in if fever is there and only 2 to 3 principal clinical features are there. These are some images of Kawasaki disease clinical features. Here is the pattern of appearance of symptoms and signs in Kawasaki disease. On x-axis, we show the weeks of presentation. Case number 2. Patient Ravi Kumar, 8-year-old male child, brought with chief complaint of rashes on legs and abdominal pain, and also the pain in both knees since 2 days. Past medical history was not significant. So on examination, found palpable purpura on lower limbs and buttocks, joints. There is mild swelling and tenderness in knees and ankle. Abdomen, mild tenderness in right lower quadrant. On investigation, found leukocytosis, microscopic hematuria, mild proteinuria, RBC cast, and both ESR and CRP elevated. Diagnosis is HSP. This is the typical rash of HSP. Case number 3. Patient, 15-year-old female, brought with chief complaint of fatigue, dizziness, arm claudication for 6 months. This patient report progressive fatigue, dizziness on exertion, and pain in left arm during activity for past 6 months. She also experiences occasional headache and have noticed weight loss. There was no history of fever or joint pain. Past medical history was unremarkable. On examination, pulse absent, left radial and brachial pulses. BP on right arm it's 130 by 80 mmHg. Left arm not recordable. Bruise were audible on over left subclavian artery and abdominal aorta. Investigation in this case were ESR of 55, CRP of 60. CT angiography showed the irregular narrowing and thickening of aorta and its major branches, particularly the left subclavian and renal artery. Diagnosis of Takayasu's arthritis type 1. Differential diagnosis for Takayasu's arthritis, we should consider giant cell arthritis, polyarthritis nodosa, and Kawasaki disease in the DDs of this. Laboratory findings in Takayasu's arthritis like MRI is widely used. CT angiography is another valuable tool, but conventional angiography remains the standard for visualizing vascular changes. CT MRI angio are increasingly being used due to non-nephrotoxic due to less radiation exposure. Ultrasound, especially Doppler ultrasound, is used for superficial vessels. Takayasu's arthritis is a granulomatous vasculitis which predominantly affects the aorta and its major branches, more common in female. Early diagnosis is very challenging because of presenting symptoms are usually non-specific. Most common complaints are diagnosis are headache, dizziness, abdominal pain, claudication. Hypertension is hypertension present in most of children at diagnosis. Involvement of aortic arch and its main branches associated with CNM symptoms and claudication. Involvement of mid aorta is associated with hypertension, abdominal pain, and lower extremity claudication. Summary for my presentation is pediatric vasculitis is challenging and complex group of conditions. The site of vessel involvement, size of vessel, and extent of vascular injury and the underlying pathology determine the disease phenotype and severity and symptoms. Most common vasculitis are HSP and Kawasaki disease. Early diagnosis, which require a high level of suspicion. With that mind and with that spec, we should see every patient, which will help to improve the outcomes. Pediatricians should consider vasculitis as part of differential diagnosis in children with evidence of systemic inflammation symptoms and multisystem disease that cannot be otherwise explained. Thank you very much.
Very well done, Dr. Gopal.
Girish,
Very well
yeah,
done.
Girish, sir.
We stuck to time, and I think he has highlighted the important vasculitis subgroups in pediatrics. I think he has covered everything, almost everything about Kawasaki disease. 2 or 3 things which I am always fond of when I talk of Kawasaki. When should you not think of Kawasaki disease? One, when the conjunctivitis is exudative, you think it is not Kawasaki disease. When the pharyngitis is exudative, so you have ulcers, you exudates over the pharynx, then you don't think that it is Kawasaki disease. Third, if Kawasaki disease can present with any type of skin lesion, but if vesicopustular lesions are there, it's unlikely to be Kawasaki disease. And fourth, if the patient has hepatosplenomegaly, then it is unlikely to be Kawasaki. Kawasaki disease, reticuloendothelial cell hyperplasia does not take place. That is an important differentiating point from systemic onset juvenile idiopathic arthritis. Special mention has to be made of Kawasaki disease in infants less than 6 months of age. That is one category in which you may have none of the features of Kawasaki except fever. Fever is the increased acute phase reactions. You may have none of the other features, and you have to have a very high index of suspicion. And if the patient does not respond to multiple antibiotics, say you have tried one combination of antibiotics, then you have tried another combination, still the patient does not improve, then you have to start thinking that probably the patient has Kawasaki disease. As a matter of fact, at all ages, if one important lesson has to be learned from Kawasaki disease, that start thinking of Kawasaki disease in every patient who has fever beyond 5 to 6 days with raised acute phase reactions. It might turn out to be something else subsequently, but at least you have start thinking along the lines of Kawasaki disease, especially because the various clinical features of Kawasaki disease may not appear all together. They all may appear at different points of time. They can be very transient. You might have red eyes only for a day, then it will disappear. You have to ask the proper history. You may have red lips only for a day or two, and then it will disappear. They don't appear all. They all don't appear at the same point in time, and hence you have to take a detailed history to be able to recognize this.
Thank
I
you,
think you
sir.
covered everything. Not sure.
Thank you, sir. Our next speaker is Dr. Swapnil Giri. He will be speaking on approach to connective tissue disease. Dr. Swapnil Giri, he's done his fellowship in neonatology, Shwas Critical Care Hospital. He's from Hingoli. I request Dr. Swapnil Giri to start his lecture.
Yes, thank you, sir. Good evening, everybody. I'm presenting a topic regarding the connective tissue disorder in children, approach to connective tissue disorder. So connective tissue disorders are, although rare in children, they are important cause of morbidity. And most of them involve multiple organ systems and associated with the presence of autoantibodies. SLE is the most common connective tissue disorders, and others are like juvenile dermatomyositis, systemic sclerosis, and mixed connective disorders and Sjogren's syndromes. So the presentation can vary from acute severe infection, acute severe illness mimicking a serious infection to the insidious onset of disease, and with a gradual accumulation of symptoms over weeks to months. And when to suspect connective tissue disorders? When there is a prolonged fever, there is a rash, unexplained prolonged fever, there is rash, there is dermal necrosis, gangrene of disease, peripheral neuropathy, unexplained arthritis, myositis, serositis, unexplained pulmonary, cardiovascular, neurological, or renal disease. There is unexplained abdominal pain or this disease with multisystem involvement. So clinical features may range from acute severe illness mimicking a serious infection to the insidious onset of disease with gradual accumulation of signs and symptoms over weeks and months. The early symptoms can be non-specific, such as fever, fatigue, loss of appetite. And when there is a multi-system involvement with no apparent cause, one should suspect connective tissue disorders. And other clinical examination-wise features include a prolonged history of fever, the oral ulcer, Raynaud's phenomena, skin rash, which is a malar rash, heliotrope rash, or nodules, photosensitivity, alopecia, pleuropericarditis, glomerulonephritis, arthritis, unexplained abdominal pain, muscle weakness, and Sika syndromes like dry eyes and dry mouth. So coming to the case, this is 15 years old adolescent girl present with history of fever, 2 months duration, and she had rashes over her face, ears, oral ulcer, and increased hair loss. On investigation, she had low HB, low WBC count, lymphopenia, thrombocytopenia, and high ESR. So this is the typical case of for SLE. And this is classic presentation which present in second decade, who is unwell with fever, arthralgia, arthritis, and may have a erythematous butterfly rash expanding or cheeks and bridge of the nose. However, the classical features occurs only in 1/3 of presentation, and rest may present with the various systemic illness. So when to suspect a SLE? SLE is typically present in the second decade and most common in girls. Then there is pyrexia of unknown origin, unexplained thyroid symptoms. Then there is a chronic ITP and autoimmune hemolytic anemia. And there is a typical age presentation for nephrotic syndrome and or encephalopathy and extramedullary pyramidal signs. So this is a typical malar rash for SLE, oral ulcer, as well as the discoid rash. So almost all systems are involved in SLE, like hematological system with thrombocytopenia, autoimmune hemolytic anemia, leukopenia, lymphopenia, renal disease with nephrotic syndrome, acute nephritis, hypertension, and then in CNS-wise, seizures, psychosis, stroke, organic brain syndrome, chorea, in pulmonary disease, pulmonary effusion and pneumonitis, in cardiovascular disease, pericarditis, myocarditis, endocarditis, in mucocutaneous disease, photosensitivity, malar rash, alopecia, oral and nasal ulcers. And GI system, there is GI vasculitis and sterile peritonitis, and musculoskeletal wise, there is arthritis and arthralgia. So laboratory investigation and clinical examination plays very crucial role in diagnosis of the SLE. In laboratory investigation wise, in general lab investigation, ESR usually is raised in SLE. CRP may be negative, may be increased. ferritin is increased, but not as much as in macrophage activation syndrome. The specific immunological investigation gives clues to the diagnosis of SLE, like ANA. They are present in more than 90% of children with lupus, and anti-DS-DNA, they are very highly specific for SLE, and they're marker of active disease, especially lupus nephritis. Complement level usually C3, C4 are low in active disease. And extractable nuclear antigen, they provide useful information on antigenic specificity of ANA. And antiphospholipid antibody, they are positive in significant pediatric patient with SLE. So coming to the diagnostic criteria, which involve clinical as well as the laboratory wise, investigation wise, out of the 11, if the presence of 4 criteria gives clues to the diagnosis of SLE, where is the malar rash is the most common with 64% of incidence. Then there is the discoid rash, photosensitivity, oral ulcer, arthritis, there is proteinuria, seizures or psychosis neurologically, pleuritis, pericarditis, blood investigation like hemolytic anemia, leukopenia, lymphopenia, thrombocytopenia, on blood investigation, and the antibodies, anti-DS-DNA, the Smith antibodies, LE preparations, and positive fluorescent antinuclear antibodies, which are present in more than 90% of the patients. So the various diseases which can mimic SLEs can be a parvovirus, eastern parvovirus infection, bacterial viral infection, the malignancies, the various types of vasculitis, and the chronic granulomatous disease like sarcoidosis and autoinflammatory syndromes. So coming to this is about the SLE, which I briefed here. And coming to the second disease, the case wise, there is an 18 months old girl presenting with a history of fever, puffiness of face, and swelling of the lips since 1 month. On examination, she had papular rash on her trunk. She was unable to roll over or sit up. The mother reported that the child has weak voice and nasal regurgitation of feet. So this is indicating toward the muscle weakness with rash. So investigation-wise, CBC was normal, CRP was increased. There is increased CPK and LDH levels. And MRI thighs showed that is altered signal intensities involving the thigh muscle. So this gives clues to the diagnosis of juvenile dermatomyositis. So coming to the juvenile dermatomyositis, it primarily affects the skin and muscle. There are 2 peaks of disease. First is between 5 to 9 years, and second is between 11 to 14 years. And it is also like other autoimmune diseases, it is common in females. There is a heliotrope rash or eyelids and gastron papules or nacules. These are characteristic of JDM. And there is proximal muscle weakness. The muscle weakness mainly affect the shoulder and pelvic girdle muscle. And it may later also involve neck, respiratory and pharyngeal muscles, which can give rise to difficulty in swallowing. Children with JDM can have vasculitis ulcer on extensor surface and GI vasculitis. Rarely the children can present with inflammatory myositis without skin involvement called polymyositis. So this is the typical papular rash present in the dermatomyositis patient. And these are the gastron papules present in the child with the JDM. So there is a Bohn and Preter criteria for diagnosis of JDM. If the rash is the must, typical rash is the must for diagnosis, and if the 3 criteria are there, then the diagnosis of JDM is definite. If 2 criteria are there, then probable diagnosis. And the diagnosis considered possible if the fewer criteria are present. These criteria are likely to be replaced since the use of MRI, where available, has made the diagnosis possible even without the use of muscle biopsy and EMG studies. So the criteria involves muscle involvement, muscle biopsy, elevation of muscle enzymes, electromyogram, and dermatological features. So coming to the third connective disorder in children, scleroderma. Scleroderma can be localized, can be systemic. So it involves the thickening of skin due to the increased collagen deposit in localized area of the skin with few autoantibodies. So they can have extracutaneous manifestations up to 20%. Juvenile scleroderma can be divided in 5 general types like plaque morphia, general morphia, bullous morphia, linear scleroderma, and deep morphia. Linear scleroderma is most commonly most common form, which may lead to the skin thickness and contracture. It progresses slowly and may involve 1 or 2 limbs. Juvenile systemic sclerosis is very rare in children. It starts with the Raynaud's phenomenon, where there is a paleness and cold numbness of the fingers. and it is also more common in female. Skin involvement includes skin thickening, head-bound skin, hyperpigmentation. Later, it may become hypopigmented, and then there is a thinning of skin. The extra cutaneous symptoms are there like heartburn, malabsorption, pulmonary fibrosis, pulmonary arterial hypertension, and arthritis. There are JDM. There are also criteria for this systemic sclerosis. Like major criteria is involvement of proximal sclerosis and duration of skin, and there are minor criteria two out of which are required for diagnosis of juvenile system sclerosis: peripheral vascular, GI, cardiac, renal, respiratory, neurological, musculoskeletal, and serological. If two criteria are present, then the diagnosis of juvenile system sclerosis can be made. Coming to the fourth connective disorder, Jogan syndrome. It is also very rare in childhood. The symptoms are dry mouth, difficulty in eating dry and food and speech, and dry eyes. The diagnosis is usually clinical, and presence of autoantibodies like ANA, anti-SSA, and anti-SSB antibodies, and evidence of lymphocytic cell disease on minor salivary gland biopsy. So in the connective tissue disorder, mixed connective disorder, it is also very rare in children. It may have features of SLE, scleroderma, and polymyositis. And the diagnostic clue is the anti-U1 ribonucleotide antibody. It is also common in 80% common in female. So there is a Kasukawa diagnostic criteria for mixed connective tissue disorder, where there should be a Reynolds phenomena of swollen finger and the anti-ribonucleotide antibody positive, and one of the abnormal findings like signs and symptoms of SLE, signs and symptoms of scleroderma, and signs of symptoms of dermatitis, any one of these. So autoantibodies plays very crucial role in the diagnosis of connective tissue disorders. Like anti-Smith antibodies, they are very high specificity of SLE, but they have low sensitivity. Anti-SSA antibody occurs in SLE, and they are characteristic of Sjogren syndromes and seen with mothers with neonatal SLE. Anti-SSB antibody, Sjogren syndrome and SLE. Then anti-ribonucleotide antibody, like we have seen just mixed connective tissue disorder. Anti-Jo1 antibody, they are highly specific and severe form of PMDM, but not sensitive. Anti-histamine antibodies are for drug-induced SLE. Anti-centromere antibody for scleroderma, Graves syndrome, and anti-topoisomerase antibody for diffuse scleroderma, and can give clue towards the interstitial lung disease in scleroderma. To summarize, connective tissue disorders are very rare in children, but they involve multi-system. The multi-system involvement is there, and evidence of inflammation, lack of any obvious cause should alert a clinician for the possibility of connective tissue disorder. Diagnosis is usually clinical with symptoms like malar rash, Raynaud's phenomena, Grotron's rash, and photosensitivity and oral ulcers. The presence of autoantibodies like ANA, anti-TSDNA, etc., they provide a supportive evidence to the diagnosis of connective tissue disorder. Most of the connective tissue disorder are treated with immunosuppressive with good success. Early recognition and prompt treatment results in an excellent outcome. So thank you all. This was all my presentation.
Congratulations, Kapil. Very good presentation.
Thank you, sir.
Before I congratulate you on your presentation, I think I must compliment you on your bravery. It requires immense courage to accept to speak on connective tissue diseases in 15 minutes. If someone had asked me to speak on such a topic for 15 minutes, I would have refused. And you did a pretty good job at that. So a few points that I would like to add. Consider connective tissue diseases in the list of differential diagnosis of fever of unknown origin. By and large, when you are confronted with a child with fever of unknown origin, you divide it into three major categories. One is infections, second is malignancies, and third is connective tissue disease. And in connective tissue disease, the commonest is SLE. The SLE is a slightly atypical connective tissue disease when it comes to approach of patient of SUO. In that, you don't get leukocytosis, you get leukopenia. You do not have elevated CRP. As a matter of fact, CRP is usually normal in SLE. The ESR which is elevated. These are the two important pointers for SLE. About juvenile dermatomyositis, one common error that I've seen people perform. If the PPK is not elevated, they remove JDMS from the list of differential diagnosis. That is erroneous. Any one of the 5 muscle enzymes that is CPK, SGOT, SGPT, LDOS, and LDH. Any one of the 5 can be elevated, then you still would have to consider a diagnosis of juvenile dermatomyositis in the appropriate clinical setting. I think that's all that I would like to add.
Okay, thank you, sir. We move on to our next lecture now, labs in rheumatology by Dr. Deepa Maitre. Dr. Deepa Maitre, she is a consultant pediatrician, Siddhi Healthcare Center, Pune, and she is a executive member, IIP Pune. I request Dr. Deepa Maitre, madam, to start the lecture.
Good evening, sir. Good evening, all esteemed speakers. My name is Dr. Deepa Maitre, and I am here to discuss labs in rheumatology. Am I audible?
Yeah, you're audible.
Yeah. Please move on to next slide. It is said that diagnosis of rheumatology is made 85% from good history, 10% from 10% from detailed clinical examination, and 5% coming from results of the lab test. The diagnosis of these conditions is primary clinical. Lab tests can facilitate screening, confirmation of diagnosis, and monitoring of the disease activity and response to treatment. However, this test should be used judiciously and always in context of clinical settings. Labs play a crucial role. There are inflammatory markers, immunological tests, blood tests, and imaging tests. Next. Objective is to support clinical diagnosis, monitoring the ongoing disease activity, assess the efficacy of therapy, and monitoring the effects of therapy. What are these tests? We usually do hemogram, CRP, urine analysis, serum ferritin, rheumatoid factor, ACPA antibodies, synovial fluid analysis, muscle enzymes, complement systems, autoantibodies. Then there are special tests like biomarkers and genetic markers. In hemogram, what happens to hemoglobin? There is anemia is seen in most of the rheumatic disorders. It indicates chronicity of the disease activity. It is generally normocytic, normochronic, but can be microcytic, as in SLE. There is autoimmune hemolytic anemia. And the WBC count is usually increased in inflammatory disorders like systemic onset GI, Kawasaki disease, then infections associated with osteomyelitis and septic arthritis. And there is decreased WBC count in SLE. There is usually lymphopenia, lymphocytes more than neutrophils. Also, in drugs like methotrexate and azathioprine can cause decreased total count, and it is also decreased in SLE. Platelets are high in Kawasaki disease, GIA, Takayasu arthritis, as it indicates ongoing inflammation. And there is the onset of thrombocytopenia. It marks the onset of macrophage activation syndrome and APS. CRP is a sensitive marker of inflammation. It is synthesized in the liver. It is an acute phase reactant. It increases early in the disease and normalizes rapidly. More reliable indicator of ongoing inflammation. More than 100-fold rise, more than 1,000-fold rise is seen, and it rapidly falls with therapy. It is elevated with inactive lupus when it is associated with infection, serositis, and arthritis. When CRPs, SLE is an exception where CRPs doesn't rise with inflammation, but ESR does rise. SLE with high CRP indicates infection with bacteria. Next slide. ESR is an acute phase reactant. It provides useful information regarding disease activity and prognostication. High ESR reflects increased fibrinogen, which is an acute phase reactant, and ESR up to more than 100 millimeters has been seen in active inflammation. Rapid fall in ESR indicates onset of macrophage activation syndrome. Now, this chart shows elevated ESR with elevated CRP indicates disease activity in rheumatological disorders other than lupus. Normal ESR and normal CRP indicates good disease control. Elevated ESR and normal CRP is seen in active lupus. Declining ESR and elevated CRP marks a possibility of in MAS as a possibility of presence of rheumatological disorders. Urine analysis is very important in rheumatological disorders, as it indicates renal involvement. Renal involvement can be a primary manifestation in HSP, SLE, ANCA, secondary amyloidosis, and systemic onset GIA. As you can see, sterile pyuria and Kawasaki disease. Microscopic hematuria, proteinuria, and cast are seen in SLE nephritis. Frequent urine analysis is recommended early for early identification of systemic JIA, polyarticular JIA. In HSP in children above 7 years have significant renal involvement seen. Next is rheumatoid factor. It is an IgM antibody directed against Fc portion of IgG. It is a inflammatory marker, and it can be increased in infections like TB, infective endocarditis, HCV, osteomyelitis, connective tissue disorders also. It is a positive value of more than 1:40 is significant in clinical context. It is useful in classification of JIA and prognosis of polyarticular JIA. Positive rheumatoid factor indicates onset of erosive disease, and according to ILAR, rheumatoid factor should be positive on 2 separate occasions for diagnosis of RA factor positive JIA polyarthritis. Serum ferritin. It is an acute phase reactant. It correlates with disease activity. It can differentiate systemic JIA from other inflammatory disorders. It elevated in systemic onset JIA, and it is helpful in early diagnosis of macrophage activation syndrome. And it is normal or slightly raised in Kawasaki disease. Anti-citrullinated peptide antibodies, called as ACPA antibodies. These are the sensitivity of ACPA for rheumatoid arthritis is 50 to 85%. Specificity is 90 to 95%. It is a useful marker for rheumatoid arthritis diagnosis. It is helpful for prognosis of the disease. ACP active, it is a marker of severe disease course. High titers of RA factor positive in positive polyarticular JIA. It indicates an aggressive form of JIA and early onset of RA factor negative JIA. Synovial fluid analysis is usually done to rule out infection or crystal arthropathy. Analysis of total and differential total leukocyte count in synovial fluid, Gram-Sen and culture is done. Non-inflammatory conditions, in non-inflammatory conditions, count is less than 2000 per cubic millimeter. Inflammatory arthritis count is usually more than 2000 per cubic millimeter. In active JI, as high as 50,000 per cubic millimeter of count, with more neutrophils, decreased glucose, increased proteins, and low complements has been found in synovial fluid. Increased interleukin-8 levels predicts activity of systemic arthritis. Hemorrhagic, when synovial fluid, when it is hemorrhagic, it indicates hemophilia, then villonodular synovitis, hemangioma. Biopsy is done to rule out tuberculous arthritis. Muscle enzymes. We do various muscle enzymes like creatinine kinase, LDH, AST, and aldolase. They are increased in inflammatory myopathies. The serum levels decrease 3 to 4 weeks prior to clinical improvement, and increase predicts on disease relapse 5 to 6 weeks later. Creatinine is first to rise and first to fall, and LDH and AST are best predictor of disease activity in JDA, that is juvenile dermatomyositis. Complement systems are high complement systems. These are high C3, C4 indicate active inflammation except in SLE, where C3, C4 is low. Like low C3, C4 is important in diagnosis of SLE. It serves to evaluate disease activity and treatment response in SLE patients. Decreased levels flare of the disease. Normalize with improvement, and inherited complement deficiency indicates early onset of SLE less than 7 years and prediction for CNS involvement. Next. Then various autoantibodies like anti-dsDNA, ANCA, and APLS. ANA is a method of detection is indirect immunofluorescence. Positive test does not mean lupus. It is usually 9 to 15% of healthy children can be ANA positive. It has a very good negative predictive value and low specificity. Conditions like scleroderma, mixed connective tissue disorders, overlap syndromes can be positive. In oligoarticular JIA, positive ANA predicts risk of uveitis, risk of developing underlying connective tissue disorders in children presenting with Raynaud's phenomenon. Anti-dsDNA, these are specific for SLE, with 60% of patients being positive. Also, it is positive in Sjogren's syndrome and rheumatoid arthritis. It is highly specific. Low titers are found in normal healthy children. It is useful in patients with ANA positive and with clinical suspicion of SLE, as it correlates with SLE nephritis and it helps to monitor disease activity. ANCA. These are the autoantibodies against antigenic components, azurophilic granules of azurophilic granules in cytoplasm and neutrophil and monocytes. It is useful. Positivity is associated with granulomatosis with polyangiitis, then microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis. These are directed against phospholipid and plasma binding proteins. These are three important APLs are all children with lupus screen for APLS baseline and annually. Lupus anticoagulant best correlation with the thrombotic events. Defer testing if patient has been started with anticoagulants. Then anti-cardiolipin antibodies IgG and IgM. High titer positivity of IgG, IgM, anti-cardiolipin antibodies on 2 or more occasions at least 12 weeks apart. Its high sensitivity of APS syndrome, but specificity is low. High titer of IgG ACL is suggestive of APS, while an elevated isolated IgM in ACL is frequently detected in infectious diseases. Transient and mild elevation is of no clinical significance. Anti-B2 glycoprotein antibodies, high titer positivity on 2 or more occasions at least 12 weeks apart, highest sensitivity for predicting APS, and triple positivity. The positive predictive value of APS is highest when all 3 APLs are positive. So next slide. Next slide. Biomarkers are in Kawasaki disease. Levels of IL-6, IL-17, IL-20, and TNF alpha are elevated in acute phase of the disease. Pro-BNP is elevated in disease with Kawasaki disease acute phase. Pro-calcitonin values in high, if high, increase the risk of IVIG resistance in Kawasaki disease. HSP, we get elevated D-dimers, urinary monocytic chemotactic protein, creatinine ratio, and HLA-B35 associated with HSP nephritis. In GI, high levels of S100 proteins and IL-18 associated disease activity in response to GIA. SLE, several blood and urinary markers predict the lupus nephritis. These are the HLA associates in pediatric rheumatology, as you can see in the chart. Thank you.
Thank you.
Thank you.
Yeah, Dr. Girish sir.
Yeah, very well presented, Dr. Deepa. Especially, I like 4 boxes that you made of ESR and CRP. You illustrate the differences between SLE, active SLE, quiescent SLE, and macrophage activation syndrome. That was very well presented. Few points that I would like to add is my personal experience with the gross misuse of rheumatoid factor. By and large, in pediatric practice, rheumatoid factor has very little role in the diagnosis of arthritis. Do not think that if rheumatoid factor is negative, the child does not have given any idiopathic arthritis. Rheumatoid factor is positive only in a small subgroup of JIA, usually presenting around the adolescent age group, who have more severe arthritis. They are the ones who have rheumatoid factor positivity. Otherwise, rheumatoid factor is a useless investigation of in the workup of GI. Secondly, when you say ANA, just do not do ANA the drop of a hat. It is very well mentioned that only the pre-test probability of diagnosis of SLE being high, only then you should do an ANA, because significant number of normal population also have a positive ANA in low titers. So if you do ANA indiscriminately, you will be saddened with the number of cases you will not know how to rule out SLE having done the ANA. So only the pre-test possibility, the patient has features which suggest SLE, then only you should do ANA. I think these are the 2 points that I wanted to add.
Thank you, sir. We now move upon to the last lecture by Dr. Atul Bonde. He will be speaking on diagnostic approach through pattern recognition. Dr. Atul Bonde is a consultant pediatrician, allergy and asthma specialist. Director, Tulip Hospital, Nashik, and Secretary, IIP Nashik 2025. I request Dr. Atul Bonde to start his lecture. I request Dr. Atul. Can you share the slides, please?
Atul sir, try now. Atul sir, you can try
Atul
now.
sir,
Atul
can you share the slides?
You can try now, sir. Atul sir, kindly unmute yourself.
Dr. Atul sir, kindly unmute.
Yes. Atul sir, you can try sharing now. Atul sir, kindly unmute yourself.
Hello everyone.
Yeah.
Yes, sir.
Kindly share the slides. Yeah.
I should share the slide, sir. Atul sir, are you sharing the slides? Or I need to share the slides?
Madam, can you share the slides?
Yes, sir, I can. But we cannot, I'm not able to hear Atul sir.
Dr. Atul sir,
Is it visible now?
Atul sir, please start sharing your screen. Otherwise, I will share your presentation.
Okay. Yeah. Please, can you share the slides?
Sir, kindly stop sharing your screen so that I can share
Yeah.
your
Just
presentation.
a minute. Yeah. I have stopped now.
Okay, sir.
Yeah.
Is it visible, sir, to you?
Yes. Good evening,
Sir, kindly
everyone.
stop.
Yeah. Uh, uh, Good evening, everyone. Today, my topic is diagnosis through pattern recognition. It's like a connecting dot. So my mainly focus will be on the pattern recognition, which is the mainly helps in the accurate diagnosis in a complex and overlapping conditions. So because pediatric rheumatological conditions rarely announce themselves clearly, their presentations are often diverse and they resembles with a common childhood illness, and they have distinctive symptoms, and they also affect multiple organ system. So as a general pediatrician, as a first responder, it is very diagnostic puzzle for us to diagnose the case. So pattern recognition helps us to solve that puzzle. Next slide. So in a pattern recognition, suppose a 7-year-old boy present with a recurrent fever, joint pain, and rashes and fatigue. So how will you come to know whether it is a viral infection, whether it is a leukemia, or whether it is GI? So mainly history plays a most important role in 85 to 90% in cases of pediatric rheumatological condition. Clinical examination plays 10%, and targeted labs plays 5% role in the diagnosis of rheumatological condition. Next slide. So we'll see different patterns like pyrexia of unknown origin, joint pains, vasculitis, connective tissue disease. Next slide. Next slide. So pyrexia of unknown origin, always remember that more prolonged the fever, less likely to it will be infection. So I have categorized in them to just before going for rheumatological condition. Suppose a pyrexia of unknown origin or a fever is for prolonged duration along with constitutional symptoms like B symptoms like weight loss, night sweats. We can consider a differential like malignancy or typical infection and autoimmune diseases. If a pyrexia of unknown origin or fever of prolonged duration or recurrent fever is involving single organ system, like suppose child is having repeated UTI, repeated upper respiratory infections, then you can consider structural problem or primary immunodeficiency syndrome. If a fever is with waxing and waning of symptom in a single episode, then you can consider a typical infection. Suppose fever is of unusual or organism at unusual site, and always consider primary or secondary immunodeficiency. Recurrent fever with similar and predictable with associated features, it can be auto-inflammatory. In case, next slide. A PO in rheumatological condition, it contributes 20 to 25%, and mainly extraarticular manifestations helps in a diagnosis of rheumatological condition. Also, other associated symptoms like arthralgia, myalgia, migratory chest and abdominal pain can be seen. Next slide. Coming back to another arthritis, pattern recognition, you must get answer to this question. First, whether it is inflammatory or not inflammatory, what is the disease duration, and how many joints are involved. Next slide. So juvenile rheumatoid juvenile idiopathic arthritis classification. Next slide. First is a oligoarticular JIA. In this next slide, in this age affected is below less than 6 years, and mainly females are affected, and it mainly involves the lower limbs. Particular symptoms is like monoarticular, and it associated with uveitis, which is asymptomatic. And serology, it may be ANA positive, and mostly it is unique feature is lower limb and symmetrical involvement. Next slide. Another Next slide. Another type is uh, polyarticular rheumatoid factor negative. There are two types: early onset and late onset. Early onset type is, both are common in females. Early onset can behave like oligoarticular JIA, and there are family histories also there. Most commonly involved joints are both limbs, and peculiar feature is wrist and small joint involvement. And also uniqueness of a feature is temporomandibular joint involvement in the uh, RF negative cases. Next slide. In case of RF positive, it is seen mainly in females between latter age 9 to 11 years of age, and in this both limbs, wrist, small joints are frequently involved. Uniqueness of feature is cervical spine involvement, erosive arthritis, and deformities. In this child, you can see that he is not able to see upwards, that indicates cervical spine involvement. Next is enthesis related arthritis. It is most commonly seen in boys with adolescent 10 to 13 years. Family history is significantly present, and joint involved is lower limbs, and mainly asymmetrical joint involvement. They have HLA-27 positive, and uniqueness of diseases, they have tarsal involvement. Tarsitis and sacroiliac joint involvement is also seen in enthesis related arthritis. Most peculiar feature is it's common in boys. Next slide. Next, next is PSA, early onset and late onset. It can be seen early onset. Uh, uh, it can be another differential for oligoarticular JIA, and most commonly involved joints are both limbs plus small joint, and symmetry is asymmetrical. Uniqueness of this psoriatic arthritis is uh, dactylitis and nail pitting, lysis and psoriasis and axial disease. ANA can be positive in 60% of cases. Next slide. Another systemic onset juvenile idiopathic arthritis. Mainly in this pattern is like a fever of prolonged duration with one of the sign like erythematous rashes, hepatosplenomegaly, lymphadenopathy, and serositis. In this labs also ESR, CRP elevated, and X-ray can show osteoporosis and serum ferritin also increase in this systemic onset GIA. Next slide. Next slide. When to consider vasculitis? If patient is having pyrexia of unknown origin with multi-system involvement, or there are persistently raised inflammatory marker with non-specific symptoms, or beyond TB, we can consider vasculitis as a differential. Next slide. This is three types, mainly vasculitis divided in small vessel, middle and large vessel. Next slide. Next slide. So mainly if you see in this large vessel involvement, you will see absent pulses, broods over aorta and vessels, cardiomyopathy or congestive cardiac failure, and forelimb BP. There will be difference between more than 10 mmHg and elevated blood pressure. In middle vessel cell, we will see abdominal pain, blindness, claudication, chest pain, deep skin changes, elevated BP. And in small vessel, we will see petechiae purpura, superficial ulcer, mucosal ulcer, and plus or minus systemic involvement. Next slide. In case of Takayasu arthritis, it is a large cell arthritis. Mainly, it is seen in females 10 to 15 years, and predominant symptoms: headache, ocular involvement, constitutional symptoms, and dyspnea and multi-system involvement can happen. Next slide. In Kawasaki disease, this chart is important. The patient can present to you between 0 days to 6 weeks anytime. So patient presenting at 1 or 2 weeks, you should know that first uh, thrombocyte count can be increased, and then there will be thrombocytopenia. Again, in case of skin changes also, initially you will see erythema, then you will see desquamation. That means in the Kawasaki disease, the patient may present at any time of disease, and we have to see retrospectively and prospectively also about the uh, different symptoms and correlate them. Next slide. So in Kawasaki disease, we'll see WBC also high, CRP, ESR is high, LFT elevated, and other things already has been discussed. We'll go to next slide. HSP pattern classic triad is pain in abdomen, peripheric rash, and arthralgia. Sometimes they have as a complication, they can have glomerulonephritis and intussusception. They may have raised ESR, CRP, and CBC also can show raised markers. Next slide. Coming to connective tissue disorders, connective tissue disorder patterns, they generally present with fever, fatigue, arthralgia, arthritis, myositis. They may have skin involvement, they have systemic involvement. Uh, Next slide. Always keep in mind that rheumatological condition always have vertical disease evolution. This means instant diagnosis is very rare, and repeated visits and repeated evaluation helps in clarity about the diagnosis. And always trust the pattern, what is developing over a period of time, and few relevant directed labs and clinical examination will help us to come to conclusion of diagnosis and further better treatment. Next slide. When you will suspect a lupus, when there is an unexplained fever, when there is a glomerulonephritis, when there is a serositis or arthritis, skin and joint involvement, unexplained multisystem involvement, unexplained neurological signs. So whenever there is a fever with many things unexplained or many unexplained system involved, then you should consider lupus in your diagnosis. Next slide. So criteria is already has been discussed. Malar rash can be present only in 50% of cases, and out of 11 diagnostic criteria must be present. Next slide. Next slide. In the labs, you can see thrombocytopenia, leukopenia, CRP and ESR may be elevated. ANA by immunofluorescence is positive, and urine may show proteinuria, hematuria, and X-ray may show effusion, and renal biopsy may show glomerulonephritis in advanced stage. Next slide. Uh, Another autoinflammatory condition is PFAPA. It is a benign condition, and it is mainly has a polygenic inheritance, and it has a fever of 3 to 7 days duration, or some particular days of duration, and they also have aphthous ulcer, which are not very large, painless, and exudative pharyngitis and cervical adenopathy also can be present, and they generally outgo by 10 years of age. Next slide. So take home message is recognition of typical disease pattern is essential, and clinical presentation of common rheumatological condition is must be known, and close clinical follow-up and reevaluation over time to establish correct diagnosis and treatment. Lab results and radiological studies to be directed to only particular suspected or diseases. It adds values, and most of the pediatric rheumatological conditions may mix with infections and malignancy. Thank you, everyone.
Thank you. I request Dr. Girish sir to.
Dr. Rasul has discussed pattern recognition in the entire field of rheumatology. I think it is of primarily great importance in evaluation of juvenile idiopathic arthritis. So if you have a child with multiple joint, 5 or more joint involvement, do not think immediately the patient has polyarticular GIA. To give you an example, if this patient who has more than 5 joint involvement began for the first time with hip joint involvement, your diagnosis is enthesitis-related arthritis. The pattern of ERA is the only GIA which can present for the first time initially with hip joint involvement. No other GIA will present with hip joint involvement. Secondly, you have multiple joint involvements, but they are asymmetrical. Then it takes you away from polyarticular GI, even if more than 5 joints are involved. So the pattern is important to know whether this patient has polyarticular GI or some other type of GI. So pattern recognition is of great importance in evaluation of children with juvenile idiopathic arthritis. But in the rest of the conditions also, in rheumatology, if you know the various patterns, it makes you easy to suspect a particular condition and evaluate further. Thank you.
Now I request Dr. Vijay sir to share his slides and give his expert opinion. Then we'll have the questions. Any questions afterwards from the audience?
I'm trying to share the slide. Okay. Is are the slides visible?
Yes, sir.
And I'm audible?
Yes, sir.
Okay.
Vijay, make it full screen.
Yeah. Is it visible or it's still?
Yes, it's visible also and it's audible also.
Okay, I am trying to. I can't see my slides. Just give me a minute.
That's okay, Vijay. Go ahead.
Okay, is this visible now, right? And full. Perfect. Audible and visible, right?
Right, sir.
Okay, I thank IIP and MAHAIP to give this chance to be on this forum tonight, and I must commend all the speakers before this because they have done a tremendous job in the least possible time. I may just want to just sum up what people have talked over the last 1 hour because rheumatology, I think, is basically about recognizing patterns. And the way I approach this on a day-to-day basis without having any burdens of thinking of general pediatrics is all of you who are listening to this talk are going to encounter rheumatology at some stage of your life. Let's start with arthritis. There are some basic rules when it comes to approaching joints that I follow. Remember that these are just the 6 or 7 commandments that I follow. Always check the age and the gender, if the child is sick or not sick, acute, subacute, and chronic. Acute is less than maybe a week or two, subacute is between 2 to 6 weeks, and chronic is beyond 6 weeks. Large and small joint, it's always a good idea to segregate the joints as large and small, upper extremity, lower extremity, and our axial, because each one of them have lead us to specific patterns. Morning stiffness versus nocturnal pains, additive involvement or fleeting involvement. The most uneducated patient will tell you एक बरं झालं आणि दुसरा ऍड झाला किंवा सगळे एकच टाइमला ऍड होत गेले. And then, last but not the least, there are concurrent systemic symptoms like, the whole list fever with the pattern of the fever, hair loss, skin rashes, oral ulcer, skin tightening, Raynaud's phenomenon, muscle weakness, limb weakness, respiratory difficulties, etc., which will lead us to a certain type of rheumatological illness. Once you have answered these questions, just put them into a simple sentence. What are the points that we covered? So, for example, I have this 2-year-old happy looking child with an ankle and a knee with morning stiffness, added involvement without systemic symptoms. Once you form this kind of a sentence, I think you can ask ChatGPT or a Gemini to answer this question. It will take you to straight juvenile idiopathic arthritis, possibly an oligoarthritis pattern. Why do these questions matter? Because always most of us know, and all the parents will say, Sakari uttanna pai adakte ani langarte. So morning stiffness definitely means an inflammatory story, whereas the nocturnal pains in a sick child often points to a malignancy, and in a happy child would probably mean a bit of mechanical issues like growing pains. A pain that gets better with rest is usually mechanical and gets worsened with activity, whereas the pain which gets better on activity is often inflammatory. The lower extremity joints, as has been summed up in the previous talks, often points to a Reiter syndrome or what used to be called as reactive arthritis. A rheumatic fever still typically is the lower extremity joints. Like Dr. Girish said, enthesitis-related arthritis is often a lower extremity joints. The combination of an upper and a lower joint, and lower extremity could be anything in rheumatology. The axial spine or the axial skeleton is the most important. Remember, very, very seldom does JIA start with the spine. Even an HLA-B27 will never start with the spine usually. When you have a child with spine, think of an enthesitis, but rule out tuberculosis and a leukemia as a primary diagnosis. When you see a child who's adding up joints with a short history, the most obvious history or the diagnosis is a post-infectious or a reactive process. The migratory and fleeting, all of us know acute rheumatic fever as a differential. Always remember that leukemics can have fleeting pains because of the marrow involvement. Last but not the least, you may, when you see a chronicity, you will probably start seeing wasting of the thigh muscles, which probably means that this child has been in trouble for long. So acute arthritis, remember, less than or equal to 2 weeks. Acute and subacute. Acute monoarthritis, you have to rule out. Remember, M for mono, M for myelitis or osteomyelitis. Please do a marrow to rule out a leukemia. Acute polyarthritis or polyarthralgias is seldom septic, often reactive. It rarely turns out to be sinister, like a paraneoplastic syndrome. Periodically, you may end up with rheumatology. A systemic diseases which can present with acute arthritis, please don't forget, before diagnosing rheumatology, rule out malignancy, and always remember that there is no reason why you need that 6 weeks deadline to diagnose rheumatology. Collagen disorders like lupus, dermatomyositis, Kawasaki can come with acute or subacute arthritis. And the golden rule I always follow is, in someone who's got joint pains within the first 1 or 2 or 3 weeks, there is often an element of pain that's more and less of swelling versus a chronic arthritis or an arthropathy where the problem primarily is in the synovium. So you will always have a lot of synovium or a lot of swelling as compared to the pain. And then obviously we've talked enough, investigations are only complementary and not mandatory. So typically these are 6 or 7 situations where you will end up with an acute or a subacute arthritis. So the most common thing that you are likely to encounter tomorrow in your OPD is post-infectious arthritis, a reactive arthritis following a Campylobacter or a Shigella or a dysentery, a transient synovitis of the hip, post-streptococcal. We are all seeing a lot of mycoplasma, but post-streptococcal reactive arthritis is a definite possibility. A single joint often ends up, you need to rule out acute osteomyelitis, nocturnal pain with acute subacute arthritis, rule out malignancies. Last but not the least, think that many collagen disorders can still present with acute arthritis or subacute arthritis. The chronic arthritis, as was nicely presented in the previous presentations, these are simple rules that I follow. Please recognize the pattern of arthritis. You don't need to sit for 6 weeks to diagnose JIA. A young girl with, let's say a 2-year-old with 2 joints or less than 4 joints with an ESR of 2. So age is less, joints are less, acute phase markers are less. Usually send an ANA which comes positive and you diagnose juvenile oligoarthritis. From a 2-year-old, if you have a 12-year-old with 12 joints and you have symmetrically large and small joints with a high ESR, so age high, number of joints high, acute phase markers high, please send a rheumatoid factor and diagnose RF positive JIA. The same child with RF negative can still be a juvenile arthritis RF negative. But if it's a 12-year-old boy instead of a girl, and typically instead of both upper and lower, you have the lower extremity joints. So remember B for boy, B for below the umbilicus, send a B for B27 by PCR method, and you confirm enthesitis related arthritis. The systemic onset GIAs, which are very frequent in our setup, remember that this child will present to you with fever, and please beware of using a drug beyond paracetamol in fevers of unknown origin because that will skew the fever pattern. The virgin systemic GIs will have an intermittent quotidian fever, which means once a day or twice a day fever. 1 or 2 days history, quotidian fever, think of malaria. 1 or 2 weeks of quotidian fever, think of tuberculosis. But beyond 2, 3 weeks, when you start running this quotidian fever, you will start thinking of a systemic JIA. The ANA positivity comes important in the oligoarticular presentations. A high ANA points to a higher risk of uveitis. And last but not the least, remember collagen disorders can also present with chronic arthritis. So to sum up the arthritis part of it, it can be broadly classified into acute, subacute, or chronic, 2 weeks, 6 weeks, beyond 6 weeks. Acute and subacute usually have more of pain less of swelling. Acute monoarthritis or arthralgia, please rule out sepsis initially. Think of tuberculosis, and then you end up diagnosing rheumatoid. Acute polyarthritis or arthralgia, seldom septic, often reactive, and rarely you will rheumatoid. Chronic arthritis, like I said, chronic arthritis means the problem is in the synovium. So you will have, remember, S for synovium, S for synovitis. So there is often more of swelling as compared to pain. Chronic monoarthritis or arthralgia, you will think of TB and malignancy and rule it out initially. Last situation is chronic polyarthritis is the rheumatologist day-to-day story, which is almost not septic. Unless the child is a newborn, you will never diagnose sepsis in a polyarthritis kid. It will invariably, you will end up diagnosing rheumatology. When it comes to labs, I think Deepa did a very decent job about summarizing the whole laboratories. As much as I would like to think labs come handy, it's very important, like Dr. Gray said, please send rheumatological tests once you have a pre-test probability of it coming positive. So the history examination will push you to sending what tests you are going to send. So remember, ANA always by indirect immunofluorescence, no ELISA from today, and it's very sensitive for lupus but not very specific. Once you screen the kid with an ANA and it comes positive and the clinical features fit, send a dsDNA and an ANA anti-Smith, which is very, very specific for lupus. The C3, C4, and I may throw in an urine PC ratio along with the ANA, which can be done at the pediatrician's level for screening lupus. So remember, screening lupus after thinking of lupus and confirm with the ANA blot. Then certain patterns that are very, very classical in rheumatology is if you have an ANA positive, the child looks like lupus, but dsDNA comes negative, but RF comes positive, think of primary Sjogren. Remember, Sjogren syndrome in children do not come with dry eyes and dry mouth. Those are diseases of a 55-year-old, not a 5-year-old. A child with Sjogren will come with red eyes, probably getting labeled as allergic conjunctivitis. They may come with gamma globulinic purpura, etc. ANA, if it comes strongly positive, has a very important role in juvenile oligoarticular presentations, which pushes the child at a high risk for uveitis. The RF and anti-CCP, you will leave it for the adolescent girl with polyarticular upper and lower joints. The B27 is, you will never send a B27 in a 2-year-old girl or a 12-year-old girl. It is reserved for a 12-year-old boy with lower extremity joints. You diagnose enthesitis. Last but not the least, if you have a child who's got sino-respiratory or sino-pulmorenal combination, you may end up sending ANCAS. So the last two important talks on vasculitis and CTD, these are very, very difficult and tricky, but thankfully they are rare to in existence. But when you see a combination of unexplained fevers with focus, unexplained fever without focus, constitutional features, headaches, and congestive cardiac failure, child coming with posterior reversible encephalopathy, feel the pulse, check the BP for discrepancy, and you have a 3-digit ESR, think of Takayasu arthritis. The next 2 months, all of the pediatricians in Maharashtra are going to see a lot of uh, uh, Henoch-Schönlein purpura or explosive onset purpura or IgA vasculitis. We all remember that the Kawasaki disease is more common in October, November, December, the winter seasons. Nobody needs any more revision about KD, but NT-proBNP is one of the marker that we started using in suspected incomplete Kawasaki's. Once in a while, if you hit a PUO with hypertension, infarcts, gangrene, evidence of neuropathy with high markers, think of medium vessel disease like the previous speaker said, diagnose polyarthritis nodosa. Uh, uh, Most of us know the dermatological features of JDM. But remember, if you see a child with anasarca with unexplained reason and difficulty in getting up from a sitting position, Remember, JDM can present with anasarca with or without the dermatological features. Remember what Dr. Giri said. Remember to send all the 5 muscle enzymes. Any one of them can be positive and confirm with an MRI. Last but not the least is an 11-year-old female with fever of unknown origin, constitutional symptoms, anemia, lymphopenia, thrombocytopenia. And remember this combination of a negative CRP and a high ESR with or without proteinuria in this kind of a setting. Please think of lupus. None of my presentations get over without this slide. This is probably your best friends in day-to-day practice. Do not separate an ESR from the CRP. If I am penning down a CRP, please add an ESR because only 4 combinations are possible. A high CRP and a high ESR could be an infection in a rheumatological story, or if it is a Nestle kid, you may be dealing with serositis or synovitis. If in a rheumatological situation or any situation you have a sick child with a very high CRP and a relatively normal ESR, you are looking at an MAS and an HLH. The next few months, again, get ready to see this combination, which could follow a dengue or a dengue-like infective story. A normal CRP and a high ESR, please remember a rheumatology story either evolving or evolved already. And last but not the least, if both are normal, you can just go and buy time and wait and watch. So I always keep saying, ab ki bar, I used to say CRP or ESR, but whether it's Shukravar, Shanivar, Ravivar, please send a CRP and ESR. Please send all of them together because that will help sort out a lot of cobwebs in your head. To conclude, rheumatology is rare or deemed rare, but it is definitely real. A good history, a good clinical examination helps you recognize pattern. The previous talks were loaded with criteria, but remember, these are not diagnostic criteria. These are just lab criteria for research purposes. You have to recognize the patterns based on what the patient shows you. Have a very low threshold and a high index of suspicion. And obviously, earlier you diagnose, better is the pickup rate, better is the treatment, and better is the prognosis. I always keep saying that the pediatrician and parents pray for resolution when it comes to all these kids, whereas I, as a rheumatologist, will always pray for evolution of symptom. If in doubt, please phone a friend. We are always there to help you out with all these mysterious stories. And in the world of artificial intelligence, where we are all learning about pattern recognition, most of these questions or queries you can put to ChatGPT and it will give you an answer. But I think what today's talks have probably sensitized or kindled in the pediatricians of Maharashtra is you have to have this pattern recognition not in the machine but in the whole in our own self. Once you start understanding and thinking that you are going to see rheumatology in your day-to-day practice every single day, I think most of the situations become reasonably easy, and it's just a matter of revisiting these presentations on a regular basis, or maybe I may say irregularly regular basis, applying them on a day-to-day basis, and seek help. I think we are more than happy to help you with difficult situations, and most of the times you will end up with the diagnosis. It's not as complicated as people deem it to be. I thank you, and I'm open for questions if there are any.
If any questions, thank you, Vijay sir, for excellent, great expert input you have given for all the lectures. I request the audience to have, if they have any questions.
I think people may be dozing already.
Yeah. So thank you very much. I thank the today's expert, Dr. Girish sir, Dr. Vijay sir, who have given a very informative session. They have guided a lot, and it was a great expert input from both of them. I also congratulate today's speakers, Dr. Rupali Salve, Dr. Gopal Ghuge, Dr. Swapnil Giri, Dr. Deepa Maitre, and Dr. Atul Bonde for the excellent lectures. I think so. I request IIP that they should make a module of all these lectures, and this module should be presented. And I request Girish sir and Vijay sir to be they should take lead for this module. Thank you, sir.
Thank you.
I conclude the session. Thank you all.